Do I have an audience who knows about what the Quebec Pharmacare program looks like? So I guess maybe it would be useful in a nutshell to give the main characteristic, what it looks like, and then I'll give you my analysis of it. So in a nutshell, the Pharmacare Quebec program covers everyone. If you have your Medicare card, you're covered for pharmaceuticals outside the hospital. That's the first thing. The second thing, it's a brainer, or it's a two-part thing. There's a public part and a private part. The public section covers about 40% of the population, and the private part is about 60%. The people who are covered with the public part of the plan are basically old age people, people on welfare, unemployed people, or people who don't have access to a private plan. The private plan is made up of multiple collective plans, mostly through employers, the type of plans that we've heard about. So in a nutshell, that's what the Quebec Pharmacare program is. So there are advantages of the plan, of course, and the first thing is that everybody's covered. So we do not have situations where somebody doesn't have access to pharmaceutical in Quebec. Everybody's covered. The second advantage is that there is some sort of mutualization of the risk throughout the population, but some mutualization. We'll get back to that. Now I'm giving you my analysis, meta-analysis of the plan. The first thing, although everybody's covered, the Quebec Pharmacare program introduces something which I call twisting universality. We are, with the Pharmacare program, going from what we understood as Canadian as a universal coverage to something which is different, which is called general coverage. And the difference is major, and we must not confuse the two. And actually, the main difference touches upon the role of private insurance. So that's why I'm going to focus on that. So if we look at the role of private insurance, we can see that the role of the private insurance is totally redefined within a general program as opposed to the universal plan. With a universal plan, the way we know it through the Canada Health Act and through the way the provinces have been implementing it, is that duplicative private insurance is drastically limited, if not prohibited. That's what the Shaoli decision of the Supreme Court of Canada was actually all about, the challenge about the prohibition of private insurance. So with a universal, basically no private insurance. With the general plan, the system is totally different because the private insurance has, within a general plan, reserved markets which become mandatory if and when it is offered through the employer or association. With the general plan, we also see something else with which we're not familiar with the universal Medicare, which is you have a basic coverage which applies to everyone, as opposed to covering everything which is medically necessary, the way we understand it with the universal plan. So when we introduce the concept of something basic, you must understand that we also introduce the possibility of having add-ups, something that adds to that, right? Which may become available to some, but not to others. So this is within the genes of the general plan. So I will summarize the main characteristic of the Quebec Pharmacare plan through 4 characteristics. They're here, so allons tout droit au vif du sujet. So the first one is what I call risk screening. The plan introduces kind of a meta screening of the whole population because the bad risks are really going to the public sector through seniors and welfare recipients for obvious reasons that we all know. Whereas the good risk, meaning people who are working and more likely to be in good health, and they're not too seniors yet, is an option for the private insurer. So that's the first characteristic that structures the plan. The second one is that the financing of the plan is actually mimicking the private insurance industry in both parts, the public part and the private part. And that is financing through annual premium, deductible, co-insurance. There's also a ceiling, a maximum contribution that is introduced, but we can see this reproduction of the private model. The third characteristic is that we find for the private insurance tax-like deduction powers. That is, that the contribution to the regime, to the plan, is done like taxes, which is payroll deductions. And private insurers cannot, not only they have the benefit of group plans exclusively, but that means that somebody could not even negotiate a private individual plan for the coverage. So only collective plans or contracts for the private insurer, which means that people who are left out, either because their employer doesn't offer it or because they're not employed, they have to go with the public regime, the public portion of the plan. And the fourth characteristic, which I think is major, and really is, to me, is a strong call to think and reflect about the long-term impact of such a plan, is that what I call here social amity is totally diffused. It is impossible to have the cross-subsidization across all segments of the population to finance something as basic and as important as we heard since this morning for equity and justice reason, for people, all people to have access to the necessary pharmaceuticals. So there is no cross-subsidization between the public and the private part, but even in between the private portion of the plan, from one employer to the other, there is no mutualization of the risk, because every plan negotiated between the employer, very often with the union, as we were reminded this morning, and the insurer, has got to be self-financed, which means that if there is some extra financial capacity within a group, it cannot be used to help a poorer group, another group where needs would be higher and revenue would be lower. So that means that the whole plan, although it is general, although it covers 100% of the population, although it introduces all kinds of little tweaks and mechanisms to make sure that nobody's left out of the system, is basically a fractured system, a system where social amity is totally diffused. And what is interesting, too, is that this plan is presented as the way of the future, the way to the future, the new way of doing social solidarity and financing of healthcare services in the country. But actually, if we look at the experience in Quebec for the last 15 years, the plan's been going on for 15 years now, and there have been some opportunities to revise and rethink the system. We never managed to really shake it up and think it twice. So, and on the contrary, proponents of the system are presenting it as the new model, which should bring us to revisit really universal system for medical services and hospital. So that was my last slide. I will just add one thing. I think that before anchoring the role of private insurance within a plan which covers the whole population of any of our province or across Canada, I think we should reflect and think twice and maybe learn a few lessons from the Quebec experience. Thank you.